A 42-year-old male presents with chronic wrist pain and limited range of motion following a prior fall. I am showing you posteroanterior and lateral radiographs of the wrist. Please describe the findings.
The posteroanterior radiograph demonstrates widening of the scapholunate interval, indicating scapholunate dissociation, with severe joint space narrowing at the radioscaphoid and capitolunate joints. The lateral radiograph shows dorsal tilting of the lunate, consistent with a dorsal intercalated segmental instability, or DISI, pattern.
What is your primary diagnosis?
The findings are compatible with a SLAC wrist, or scapholunate advanced collapse, secondary to chronic scapholunate dissociation.
How do you diagnose a DISI deformity on a lateral radiograph?
A DISI deformity is diagnosed when the scapholunate angle is greater than 60 degrees, indicating dorsal lunate tilt and volar scaphoid tilt.
What is the normal scapholunate angle, and what does a decreased angle indicate?
The normal scapholunate angle is between 30 and 60 degrees. A decreased angle of less than 30 degrees indicates a VISI, or volar intercalated segmental instability deformity.
What is the biomechanical progression of a SLAC wrist?
Scapholunate ligament disruption leads to proximal capitate migration into the scapholunate gap. This alters loading kinetics, leading to progressive cartilage wear beginning at the radial styloid and progressing capitolunately.
Which joint is characteristically spared, and why is this clinically important?
The radiolunate joint is characteristically spared. Sparing of this joint is a crucial prerequisite for performing a proximal row carpectomy.
What are the common underlying etiologies for SLAC wrist?
The most common etiology is trauma. Non-traumatic causes include chronic inflammatory conditions like rheumatoid arthritis and calcium pyrophosphate dihydrate deposition disease, or CPPD.
Finally, what are your clinical management recommendations?
I recommend referral to an orthopedic hand surgeon for surgical options, which may include a proximal row carpectomy or four-corner fusion. I would also suggest comparison with prior wrist radiographs to evaluate the progression of collapse.